Hello, everyone, and welcome all the attendees and the panelists to the first IFSO MENA webinar in 2025 between Faith and Physiology, Ramadan fasting after metabolic and bariatric surgery. This webinar will be recorded and will be available at IFSO YouTube channel and IFSO Academy. My name is Ala Wafa. I'm a consultant in metabolic and bariatric surgery, assistant professor of surgery in Misrata University, and vice chair of the communication committee of the IFSO MENA. Our presenter today is Dr. Salam Abu Naja. He's a consultant metabolic and bariatric surgeon, associate professor of surgery, West Virginia University. Our moderator, and this session will be moderated by Muhammad Abu Zaid. He's a professor of surgery at Ain Shams University, consultant metabolic and bariatric surgery at Ain Shams University, and chair of the communication committee of the IFSO MENA. The panelist will be Professor Abdurrahman Nimeri, Director of Metabolic and Bariatric Surgery at Brigham and Women's Hospital, Harvard Medical School, past President of the IFSO MENA, and Secretary Treasurer of the IFSO. And the other panelist is Dr. Mohammed Kirman Saravi. He's a consultant metabolic and bariatric surgery, Associate Professor of Surgery, Iran University, and Chair of Scientific Committee of the IFSO ABC. So I will leave the stage for Dr. Salam Abu Naja to start his presentation. Dr. Salam, stage is yours.
Well, good morning, good afternoon, good evening, everyone, based on where you are. I am very honored, and I really appreciate this great opportunity to present to you today. A lot of thanks to my friend Ala Abu Wafa for this great invitation, and I thank all the panelists, and special thanks to Dr. Abdurrahman Numeri, one of my dearest friends. So I'm gonna get started. So for all the Muslims joining today, Ramadan Kareem and Kull Aam wa Antum Bikhair. The objectives of my talk today, I divide them into three parts. We're going to have an introduction into fasting and Ramadan in general, and then we'll review the data available, and then I'll try at the end to put my personal view on this and put everything together from what I've gathered over the time I've been preparing for this talk and the time we published our paper last year. So, as many of you know, Ramadan is one of the 5 pillars of Islam. During Ramadan, Muslims will fast for the entire month of Ramadan from dawn to sunset. This includes no eating, no drinking, and abstaining from any intimate relationships. And this continues for the entire month of Ramadan. It's so important for Muslims, and if you end up not fasting during that month for any reason, end up breaking your fast, you're supposed to refast an equal number of days, as in Surah Al-Baqarah, whoever is ill or on a journey, then an equal number of other days, meaning you have to fast an equal number of other days. So it's a big deal for a Muslim to break his fast. So if you had asked a patient to break the entire fast in Ramadan for 30 days, that Muslim is supposed to fast those 30 days later in life. So it's a big social and religious obligation, and it's not, Muslims don't take breaking the fast easily, and that's very important for bariatric surgeons to understand. So beside all the spiritual benefits of fasting and why it's part of many religions, there's Muslims and in many other religions believe that fasting has also some health benefits. Prophet Muhammad, peace be upon him, said, "Sumu tasihhu," meaning fast and you'll be healthy. He also said in another quote, "It is sufficient for a human being to eat few bites to keep his spine straight," meaning few bites will allow someone to be healthy enough and keep himself straight and surviving. So fasting, has in religion has also some health benefits, or religious people believe in that. And it's not just unique to Muslims or Islam. Jewish have similar fasting practices, that they have the 6 days of minor fast, which is from sunrise to sunset. They have the major fast, which is 25 hours of fast. Catholics will fast, which is coming up, the Ash Wednesday, the Lent, which is from the Ash Wednesday to the Good Friday. Mormons fast 24 hours, one Sunday a month. And then Buddhism have a more flexible kind of fasting from noon to dawn. So fasting has been there for thousands of years in many, many religions. And again, similar to Islam, in those religions, There was a spiritual and a religious reason for fasting, but they also believed that this has health implications like detoxification and improved digestions and so forth. However, for all those years, it wasn't we didn't have a good scientific basis beside just weight loss. We didn't have any at the cellular level. We didn't understand what fasting does to the body until in 20, in the early 2000s, Dr. Hosomi, who basically discovered and did a great work on autophagy, and he won the Nobel Prize in 2016. This coming slide is a little busy and was not intended for this talk, but I stole this slide from one of my presentations a year ago talking about longevity. It talks a little bit about autophagy, and I felt it was really good introduction for us to understand how fasting works at the molecular level. So autophagy is this quality control measure where the body cleans up and the cells will clean up, get rid of dead cells, and unused proteins, and think of it as your project manager that kind of clean up the mess when you're building something. And autophagy is basically controlled by two systems, the mTOR and the AMPK system. And basically, when we have abundance of food, especially protein and high amount of calories, and there's insulin and growth factors, especially this is in the times when we feast and there's a lot of food available for us. This tends to stimulate anabolic processes and cell growth and lipid synthesis. On the opposite, and it does inhibit autophagy, as we can see on this part. However, on the other end, if we have lack of, or there's decrease in the amount of food we eat, there's decrease in amino acids and glucose and oxygen, we tend to stimulate the AMPK, which is what is similar to fasting or calorie restriction. And that tends to stimulate autophagy and inhibit growth. So to make it easy, many young individuals will eat too much, thinking by eating too much, they will bulk up and build a lot of muscles. But the reality is, unless you use a lot of steroids and work out in the gym every day, you end up actually gaining weight if you eat too much. On the other hand, if you are fasting or you're restricting calories, you go into a survival mode, similar to that Castaway movie, where you are actually it promotes longevity because you're stimulating autophagy. And this is at the cellular level. And of course, today, this is not the day to talk about this. But again, this slide was ready for me, and I thought it might be kind of nice to share to understand the relationship of at the molecular level, how fasting or restricting calories work. And one last slide about that. This is a simple study looking at mice and their survival. By restricting calories by 25%, the mice lifespan extended by about 5 months. By restricting them up to 55%, they actually almost doubled the lifespan of the mice. And I think out of all people, bariatric surgeons will understand this the most, because after all, this is what we do for our patients. We actually, in one way or another, in different mechanisms, we make them eat less. And that's why we have so much evidence and data to suggest that bariatric surgery does prolong longevity and prolong lifespan and health span. And that's kind of perhaps the basis of why fasting might be healthy for the human being. And this is obviously a big topic that's being investigated and looked at. Now, I took a little side tour, so I'm going to go back now to our topic, which is Ramadan and Islamic fasting and bariatric surgery. So before I talk about the data, I want to explain something for people who are not familiar with how the lunar calendar works. So every year, the month of Ramadan is going to move 10 days earlier. So this year, the Ramadan starts on March 1st, 2025. Next year is going to be 11 days earlier. So it's supposed to be around February 17th or 16th. The next year is going to be early February. The year after that is going to be in January. So basically, the month of Ramadan moves every year 10 days on our calendar, 11 to 12 days on our calendar. And that is very important for us to understand when we place our guidelines and recommendations. There's also another important factor that plays into this, that the Earth, as many of us will know, has a tilt or an axial tilt about 23.5 degrees, which means that during summertime or in June, countries in the north are going to have summertime because they're closer to the sun, where the day is going to be much longer and the temperature is going to be much hotter, while countries in the south are going to have actually winter during that time. And that changes throughout the year because of that axial tilt of the Earth, which is also important for us when we make our guidelines, because the guideline we make today will be completely different in 10, 20 years from now when the Ramadan moves closer during the year. And an example of this is like, extreme examples. If you live in northern Norway, you will have the midnight sun in June where the sun never sets. And in winter, you will have polar nights where it's night throughout the entire day. So most of us don't live in northern Norway. However, even in regular cities, for example, this is in New York City. If you look at New York City, the average daytime, this was in June of 2024. In New York City, the average daytime during June is about 15 hours. So if you're fasting in June, you're fasting for 15 hours a day. However, in December, the average daytime from sunrise to sunset is about 9 hours. So if you're fasting Ramadan in December, you're only fasting for 9 hours. So it's important for us to understand that Ramadan is not fixed. It changes every year. It takes about 33 years to go back to the same month. So if we look at one last thing I want to kind of highlight is the difference in cultures. So this is a picture of Cairo at 2 a.m. in Ramadan. You can see how the streets are busy. People in a Muslim predominant country will shift into a nocturnal lifestyle during Ramadan. So they have much longer extended hours to eat and drink versus this is a picture of West Virginia at midnight in a Ramadan. So it's a completely different perspective if you have to wake up early and work and spend very few hours at night to be able to eat and drink. And that makes a big difference. So I think that's an important factor that many of us don't consider when we think about these guidelines that we place. So now let's get into the data and what we have. And unfortunately, it's very limited. So this is the ASMBS surgery review on fasting for religious purpose. This was done in 2022. These experts met and they tried to put together some recommendations based on reviewing the data available and their expert opinion. And I have to notice that obviously this comes from the US. Although some of the surgeons here may be Muslims and have an Islamic background, they do not practice with patients that fast, or a big percentage of patients that fast. It's different from a bariatric surgeon who lives in a Muslim predominant countries who see patients fasting every day, and that's I think makes a difference sometimes. So what they found, they did the systemic review. They only found 4 studies that examined fasting after bariatric surgery. The majority of the studies they looked at were about fasting in non-bariatric patients. And they relied heavily on the modified Delphi consensus that was published by Dr. Kerman Sarabi that we're going to talk about in few. And this is where they came up with the recommendations. And I have to say the recommendations were very, very vague. There's really not much to talk about. The main thing that most of us want to know is how soon could patients fast? And if you look at their recommendations where they stratified patients to either high risk or low risk patients, they basically stated that if you're within the rapid weight loss period, which is 12 months for kind of restrictive operations and 18 months for more metabolically active operations with some degree of malabsorption, is 12 months and 18 months. They do not specifically say that's the safe time to fast, but they're saying if you fast within that time period, you are at a high risk. And of course, the high risk category include a lot of listing things that I will think they're not necessarily bariatric surgery related. They are more like a common sense or just for a normal individual. If you're old and you have active disease, you probably shouldn't fast. It's an easy thing to comment on that. Things like social support or living alone are very vague and hard to quantify. So it's hard to I don't want to be too harsh. I think it's a great attempt for them to try to summarize the data, and there's unfortunately no data, so they cannot come up with very good recommendations. And I didn't find this to be very helpful if I was looking at this review of system to try to guide my patients. And that's, we'll move on to the next study. So I'm going to try to look at some of those studies that they reviewed. So one, and I'll say this is I think as far as I can tell, the first study that specifically looked at bariatric surgery and Ramadan, and this was published by a Kuwaiti group in 2015. And they basically did a telephone survey for patients, 207 sleep patients. They called them during Ramadan, the second half of Ramadan, once they're settled in their fasting, and they call them 4 and 8 weeks after Ramadan. They try to collect data from them, mostly 24 hours food recalls. They asked about hunger, they asked about adverse side effects, they asked about the medication use. And for those patients, the mean average was 14 months. So we're talking about patients who have past the 1 year of bariatric surgery. So it's not early in their post-bariatric surgery journey. And in a nutshell, they found that fasting with sleep gastrectomy or after sleep gastrectomy was safe and well tolerated in this group. They had no significant differences in fluid intake, surprisingly. However, they noticed that energy consumption and protein intake was a little lower. They noticed that patients perceived themselves as less hungry than when they were before bariatric surgery. And they noticed that there was some decrease in weight in at least 50% of the patients. And more importantly, they noticed that most patients were able to comply with their medications, their vitamins and so forth, almost 90%. So this was a really good start, and I think it was an excellent study to perform. There was almost no data about bariatric surgery. Now, moving on, there was another similar study. I'm not going to dive into it too much because it was similar concept with way less number of patients. And it's basically based on a pre-Ramadan survey, post-Ramadan survey. However, there was only 52 patients in this study, and only 19 of them completed the post-Ramadan survey. So it's really hard to use this paper to come up with any kind of a meaningful conclusions. However, they concluded that basically Ramadan did help with some weight loss. It did not have any significant adverse effect. And more importantly for them, they were looking at socialization. And they thought that Ramadan helped patients fit in the society fasting helped patients fit in the society very well and perform well from a social level. So their message basically that it might be beneficial for patients who post-bariatric surgery to fast if they're able to fast. So now, one of the most important, I will say, landmark articles, or I'll say it's a resource for us, or the first, at least some degree of guidelines came up from this beautiful survey that was done by, or modified Delphi census that was done by Dr. Kerman Saravi and a group of experts, including Dr. Abdurrahman Numeiri. And in this particular Delphi consensus, it was basically based on expert opinions. They recruited 61 expert bariatric surgeons. So it's from the get-go, this is not based on data. It's based on expert bariatric surgeons who work with patients who've had bariatric surgery and are in Muslim predominant countries. So they have a very good experience dealing with the patients. And basically, it was 2 rounds of voting, and anything that achieved 70% agreement among all the experts was considered a consensus. And they reached about 40 out of 45 statements. So it's a very, very beautiful concept. It makes up for the lack of data that we have, and it really gives bariatric surgeons a good insight on what and what to advise their patients and help at least guide their decision making. So I'm not going to go over the 45 obviously points, but I'm going to highlight some of the important ones. Some were very straightforward, and I get 100% agreement, like that the decision making should be shared between the surgeon and the nutritionist and the patient. I think kind of a straightforward. But I think for the most important parts, there was no consensus. For example, like the ideal time for fasting, there was no consensus if 2 to 4 weeks was too early to fast. There was no consensus if 3 months after bariatric surgery is advised as a good point to fast. There was no consensus if 6 months, at least 6 months, is good for restrictive operations or restrictive procedures, patients to fast. The only consensus was for malabsorptive procedures or combined malabsorptive procedures. 6 to 12 months seemed to be ideal. They agreed that delaying fasting to 6 to 12 months was ideal for patients who have malabsorptive operations. So again, there wasn't a lot of consensus, but on the hot topics, they all agreed that giving PPIs, at least in the first 6 months after metabolic bariatric surgery, was a good idea, which kind of I think is a great idea. There's data support even without fasting that in the first 3 to 6 months for patients who have gastric bypass, it could minimize early marginal ulcers. They basically, all of them agreed, had a consensus that they did not believe that fasting did induce marginal ulcers or increase the incidence of marginal ulcerations. And then, generally speaking, on the beneficial parts of fasting, almost all of them agreed that fasting had actually beneficial benefits for their patients. So, so overall, great resource for bariatric surgeons, but it's important to keep on pointing out that there's no direct evidence that this was relied only on expert opinion that there could be potential biases, even though it's a Delphi consensus. And there's also lack of stratification by surgical procedures. It did not specify each procedure and so forth. So again, this was a good start. Now, the next paper I'm going to look at, and I'll say I'll be a little critical of this paper. I have a little bit of criticism for this paper because I think the concept was novel. They were trying to look at complications after bariatric surgery, and they were getting, again, an international survey asking patients about what complications they've seen during fasting or during the month of Ramadan for their patients. I think the concept is novel and it's great, and there's almost nothing like it. But definitely the analysis of the complications and the conclusions, I'll be a little critical of that. So this, again, was an international survey. There were 21 centers, 11 countries, 132 patients in total. They basically they asked all the surgeons or all the centers to report their complications on patients who are fasting in Ramadan of 21 to 22. The mean time between surgery and onset of complications was, again, about 14 months. So most of those patients were not fresh out of surgery. And the average fasting duration for most of those patients was about 12 hours a day. The big thing that there is obviously a clear selection bias because the centers are going to select their patients to send to the group. There's no control group to compare to. And the biggest thing to me was there's a lot of potential confounders. I mean, in a nutshell, not just because someone had complications while they're fasting, it means it's caused by the fasting. And that's a very important thing to understand. If you had a marginal ulcer while you're fasting, it does not necessarily mean that it is caused by fasting. It's hard to prove that or show that with certainty. So their patient group was very variable. There were some of the big, numbers from sleeve gastrectomy, one anastomosis, gastric bypass, or Roux-en-Y, but they also included small percentages of other less commonly performed operations, which I think could also skew the data a little bit. I'm surprised they used the Kelvin-Dendo classification for the complications, which is commonly used only for the first 90 days after surgery. There might be some exceptions, but generally speaking, it's not commonly used for complications 14 months after surgery. I will focus on the main complications like marginal ulcers, kidney stones, and perforations, but they've included things like an acute cholecystitis, which we know is a very common condition in general. And if someone had acute cholecystitis during Ramadan, does not necessarily mean it's caused by the fasting. They've included GERD, which I'm not clear if that means exacerbation of GERD during Ramadan or new onset GERD. So there's a little bit of vagueness here, but I think the most important thing I want to focus on the big complications that they reported. So if we look at, for example, they recorded GI bleeds and sleeve gastrectomy. I'm not sure, sleeve gastrectomy is not commonly known for having GI bleed, and there was no specifics. Is this a GI bleed from a duodenal ulcer? Is it from the stomach ulcer itself? And that is also not a known complication as far as I can tell for a sleeve gastrectomy, unless it's a clear pathology. They've also included a perforated duodenal ulcer in a sleeve gastrectomy patient. And again, I could be wrong, but I don't know that a duodenal ulcer perforation is necessarily a complication of a sleeve gastrectomy. It could happen in a sleeve gastrectomy patient like it could happen in someone else. There's data to suggest that during Ramadan fasting, duodenal ulcer might be increased, or there's increased acidity that could relate in duodenal ulcers. But again, this is not very specific to a sleeve gastrectomy. And then the last thing, because I don't want to take too much time, all these marginal ulcers, there are many smokers in that group. And if we look at 21 centers over 2 months period and 2 Ramadans, even if we sum all those ulcers together, there's still not a huge number when you compare 21 major centers. So it still could be just a coincidence that these marginal ulcers were diagnosed in Ramadan. So it's hard to go with any certainty to say that these are complications of fasting and metabolic surgery in Ramadan. Finally, the kidney stones. There's 6 patients with kidney stones, and many of them had malabsorptive operations, which we know increase the incidence of kidney stones. However, urologists have looked into this, and this is a big systemic review that shows there's unlikely that fasting can significantly increase the risk of kidney stones. So we don't know that for certainty as well. So it's hard to say just because patients had kidney stones during Ramadan that this is caused by the fasting in Ramadan. So for the sake of time, I'm going to skip over some of the recommendations, but generally speaking, it recommended that we use PPIs, that we drink plenty of fluid to prevent kidney stones formations. and so forth. Now, the last two studies, which I think were published recently, one was a collaboration between myself and Dr. Ala Wafa, which I think has the biggest number of fasting patients post-bariatric surgery. And this study, we looked at early fasting, meaning this is the first 12 months after bariatric surgery. This had 376 patients. We had a combination of retrospect chart review, but we also have direct patient contact via phone calls, pre and post Ramadan. And we looked at something which I think is very important for us. And this is a breakdown of the patients. We had 99 one anastomosis gastric bypass, we had Roux-en-Y, and we had 257 sleep gastrectomy. We looked at something which is the intention to fast, which is in a Muslim predominant country like Libya, was almost 100%. So almost 100%. There was 98% patients who wanted to fast before Ramadan. They intended to fast regardless. And only 8 said they're not going to fast. And out of the 8, surprisingly, 5 of them end up fasting the entire month. So only 3 patients out of the entire group of patients we had did not want to fast, or at least attempt to fast in Ramadan. So which is a very, very important for us. We also and only if we look at the people that fast, only 9% broke their fast, and they did not break it for the entire month of Ramadan. They only break on average about 8 days. So basically, they attempt to fast and they broke some days. And for the most, this was within the first 4 months of surgery, or after, within the first month. So these are very early post-op patients. The ED visits, we had about 2.9%. 90% of our patients in the study have actually lost weight during Ramadan, but this was consistent with the weight loss after bariatric surgery for the most. The earlier they were to surgery, they lost more weight. And the average fast time was about 12.5 days. And these are some of the side effects they had: dehydration, weakness, nausea, and so forth. And basically, we conclude that the overwhelming majority of patients wanted to fast, the complications rates were low, and that it was not as harmful as we thought for our patients to fast within the first 12 months. And more importantly, patients wanted to fast regardless of our recommendations. So finally, the last study, which is very similar, beautiful study done by Dr. Abdul Baqi in Alexandria in collaboration with Frankfurt, and basically similar vibe. They had it's a prospective online survey. There was before and after Ramadan, 218 patients. They had a control group of non-bariatric patients, and they looked at how many did they fast, what side effects they had, their satiety, hunger, their dietary recalls, and so forth. And for the sake of time, I just want to show up like the numbers, exactly similar pattern to our pattern. After 9 months, almost all patients were completely fasting the entire month of Ramadan. Patients who are very early, within the 3 months, did attempt to fast, some of them, and some of them were able to fast, but it was not very successful for the entire month. And anywhere between 3 to 9 months, there was a variable degree of fasting. But for the most, the longer you are out of surgery, up to 6 months, you're usually successful in completing the whole month. And the side effect profile was very low, mostly constipation, which is very common for most people, including people who have not had bariatric surgery. So putting everything together, again, they had similar pattern of weight loss, which is the early after surgery, the more weight loss, nothing more for bariatric surgery. They concluded that fasting patients reported decreased feeling of hunger, and they reported that weight loss was primarily attributed to surgery, with maybe partial contribution from fasting. Now, time to put everything together. What did I come up? This is data that's available. There's not much data, but what did I put together in terms of what should we look into and discuss after I finish, and put steps to maybe moving forward with more recommendations. I think it's hard to put specific guidelines, so I want to have more like a roadmap. So the question number 1: when to fast post metabolic surgery? I think it's a scoring point. They have to look at first. So low risk, if it's the shorter fasting hours, less than 10 hours, if it's a favorable weather, and if it's a Muslim predominant countries where patients can be up more at night and eat more and drink more, and if they had a restrictive operation like a sleeve gastrectomy, it may be very reasonable to consider 3 months as a good starting point. But after 3 months, potentially it's safe for those patients to start fasting. If it's a moderate risk, meaning the average fasting hours, let's say roughly, again, these are just numbers, anecdotal numbers I came up with. 10 to 14 hours, it's a reasonable weather, the country has a majority Muslim population, and they had a Roux-en-Y or an 1 gastric bypass. It might be reasonable to think 6 months might be a good starting point. And again, this is not a recommendation. This is just a way for you to think about this. And then finally, if it's a high-risk patient, if the patients have long fasting hours, more than 14 hours, they live in, extreme kind of a long fasting hours, let's say in June in Northern Europe. If it's a hot weather, if it's a Muslim minority country where there's not a lot of adjustment that could be made during the fasting hours, and if they had a hypoabsorptive or a more aggressive malabsorptive operation like a SADI or a DS, then maybe 12 months is a good time frame. But again, these are not guidelines. What other than that, what dietary recommendation? I think we have to keep it simple. We're so focused on percentage of protein and carbs and this and that, which is most of the time patients will not understand and will not follow. I think keeping it simple, recommending to drink water over sugary drinks and emphasizing that, recommending to perhaps satisfy your sweet craves with something healthy like dates that have magnesium and potassium and fibers and so forth over, a piece of cake when you break your fast or have sahur. Highly recommend eating a lot of vegetables and fruit to avoid the constipation with a lot of fibers. And also vegetable fruits are rich with electrolytes and they're rich with fluids. So they help fight the dehydration that could happen. Over recommending a very high protein diet that's full of saturated fat and salt that will make them actually constipated. And from what we see, there's not really evidence that a month of fasting could affect the body significantly from a protein level. And I think it might be a good idea for us to have handouts in our clinics for Ramadan recipes that are good for patients, so it's easy to hand them out before Ramadan. Finally, pre-Ramadan preparation. I think you have to follow just a natural course. It may be tempting to say in the recommendation, well, before Ramadan, we have to test everyone. But the truth is, if you live in a 100% Muslim community, you cannot call all of your patients before Ramadan and test everyone for all micronutrient deficiencies. That's just not practical. So I think follow the same post-operative course. If they're up to date with everything, then you don't need to do anything before Ramadan. I don't think you need to check labs. Again, these are my personal opinion, just to be clear. I don't think you need to do an ultrasound for kidney or gallbladder stone because I don't think it will change your management. So we should be doing ultrasound for every patient before Ramadan to check if they have kidney stones or gallstones. And finally, I think PPI is a good investment. It's a very low risk, it's cheap, and maybe it will help prevent some of the ulcers if they are indeed caused by, or there's an additional risk of fasting. We don't know that, but it's a very low risk investment that maybe we could recommend PPIs for patients. Final thoughts. I think fasting is a very personal decision, and I may disagree on the consensus that it's not made by the surgeon and the dietitian. It's mostly made by the patient. They are the one that are going to have to fast later if they don't fast in Ramadan, so we can only provide guidance. We want to avoid the all or none approach. We shouldn't be overprotective. Patients should attempt to fast if they want to fast. And if they can break their fast if they feel dizzy or dehydrated and so forth. So it doesn't mean they have to fast the entire month if they attempt to fast. But I think it's reasonable to be more liberal in allowing patients, if they wish and it feels safe for them to fast. And finally, we have to be practical about our recommendations, and we shouldn't be chasing every little thing. So we shouldn't be trying to come up with recommendations for pregnancy after metabolic surgery, because pregnant ladies will have their own unique things. They have their own gynecologists to look into their health and decide based on the stage of pregnancy and so forth. We shouldn't be digging deep into diabetics and so forth. That's why we have endocrinologists that can monitor their blood sugars and so forth, extreme of age and so forth. So for our recommendations or roadmap, we are assuming patients are healthy enough to fast. We're not going to have to complicate it with many other things. So that's basically it. And I would recommend, hopefully in IFSO, maybe in 2025, we could maybe get together and come up with more and discuss this further and see if we can come up with an IFSO specific roadmap that could be helpful for the patients. So I apologize if I took too long and I rushed through the slides. I think I put more than what I thought I could in one presentation, but this was a very interesting topic and I could not cut it short. So and that's basically it. And this is West Virginia. So any questions?
Thank you, dear Dr. Salem. It was very, very good presentation and it covered everything. I will just ask the panelists to say their experience and their practice with the fasting for their patients, and then we will discuss together a guideline or roadmap. As you said, I really loved your last slides about the roadmap for the fasting. So let's have like a consensus today of what to do with our patients. We'll start with Dr. Abdulrahman. Please, Dr. Abdulrahman, start your
Sure.
talk, and then Dr. Muhammad.
Sure. Thank you, Muhammad, and thank you, my dear friend Salim. I really enjoyed your presentation, and I have to come and visit this nice location in West Virginia. You're not far from me. I mean, I do agree with Salim in many of the points he said, and I think the criticisms he levied are well-founded. I myself, when I practiced in Abu Dhabi for 9 years, used to tell patients a similar strategy to what he said. So I would let them actually fast liberally 2 weeks after surgery. And I would tell them my recommendation is that they wake up before suhoor and they focus on drinking and then eating mostly yogurt. And then I would tell them not to eat dates at iftar and to only drink warm things like soup and eat yogurt between iftar and tarawih and eat after tarawih. And I tell you, for 9 years doing that strategy, we got most patients to fast, with the exceptions of patients with type 2 diabetes. So even though the publication, reflected the majority, I personally have done most of what Salim has been saying. I let people fast liberally, and I usually tell them 2 weeks. And we did this for 9 years and did not have significant problems.
Dr. Muhammad Kerman Saravi, please, your opinion. Dr. Muhammad Kerman Saravi. Hello? Do you hear us?
He might be frozen, so maybe we'll have Ala comment.
Yes.
Thank you, my friend Salim, for this outstanding presentation. But I have just one question to both Salim and Professor Abdurrahman Nemeri. So we have seen that despite medical advice against fasting, there is one study called Ramadan fasting and diabetes. It's not for metabolic bariatric surgery, but just collaboration with Ramadan fasting and diabetes by Gobert in south of France demonstrated that 53% of those patients with diabetes still choose to fast even against the medical advice. So Professor Abdurrahman, how you deal with the metabolic and bariatric surgery diabetic patient who is intended to fast?
Sure. And I think it's an excellent question, and I think diabetes is a wide disease, and I would separate someone who takes insulin from someone who does not take insulin. So for patients who do not take insulin, we typically let them fast, and most of them typically are not taking, things that will make their blood sugar go down. So, like Salim said, we let them give it a try, and if they have issues, they could break their fast. I think what I don't have experience with is the new GLP-1 receptor agonists. And I'm not sure what's the recommendation, because for most of our patients, at least when I was in Abu Dhabi, even if they were on GLP-1 receptor agonists, we stop it after surgery. So I don't have a good experience with patients on GLP-1 receptor agonists, although just asking our endocrinologists here in Boston, they tell me that many patients struggle if they're on GLP-1 receptor agonists similar to insulin. But typically it's a liberal recommendation, and they can break their fast if they have issues.
Yes, Professor Abdurrahman, because we have attendee here asking a question. His name is Abdul Hamid Hamdi. He's asking about GLP-1 post-sleep and during fasting, how to deal with him.
So I think for diabetes, I have to, and again, this is a different topic, but we have to understand that people actually use intermittent fasting, and there's a big, data about it to treat diabetes. So I think the fact that we debate if someone with diabetes could fast or not could be a little ironic if some people are actually trying to treat diabetes with fasting. I think today in 2025, there are continuous glucose monitors that patient could wear, and they have, you know, alarms to their phones that could help tighten their blood sugar control. I think it all depends on as Abdurrahman said, you know, how severe is the diabetes, how much insulin are they on. I won't even say if you're on insulin you shouldn't fast, because we know most Muslims who are diabetic fast, you know. So the truth is, again, it's hard to make a specific recommendation about an individual and a population, but I think for individual, most, I will argue, could fast unless they have advanced disease. They have chronic kidney disease, they have retinopathy. I mean, if the stakes are very high, then I think at that point, you know, that's a different story. But just the fact that someone has diabetes, I think, you know, and they strongly believe in fasting. I mean, first of all, they're going to fast regardless. So might as well you give them the guidance and the support to fast, and not just give a blunt recommendation of, if you have diabetes, you shouldn't fast, or it could be dangerous for you. I think that is a debatable subject that in my world, I think, as Abdurrahman said, I think we should be a little more not overprotective and let patients make decisions, provide them guidance. And I think in today's world, with the excellent monitorings that we have, it is much safer to fast than many years ago. And I think that's something we could switch them to some sort of a sliding scale and so forth. But again, this is where the endocrinologists have to take the role, and we don't have to, as bariatric surgeon, be necessarily the one making those guidelines. I think we should treat them like other patients, you know, with diabetes, and not just because they have bariatric surgery, we have to come up with specific guidelines for our patients. I think the GLP-1 question is a very good question. I have extensive experience with GLP-1, but I don't have a Muslim community to tell you what happens after Ramadan. And this is where I may pretend today to be an expert, but the truth, I don't have the experience you guys have, because I don't deal with patients who are fasting. All the experience I have comes from what I learned through the data and through the study we did together, but I don't really have personal experience with patients who are fasting. And that's, yeah, hopefully that was answer the question.
Actually, in my experience, in my practice, in Egypt, it's complete, as you said in your presentation, and it's completely true that in Egypt is different from any other country, even maybe like Saudi Arabia or Jordan, but maybe another quiet countries like Abu Dhabi, Dubai, UAE, they will have another kind of day pattern. In Egypt, the day pattern for most of the patients, and I usually ask about the day pattern before I recommend fasting in the first month after the operation, because sometimes I will say that after 1 month you can fast, but you have to have the day pattern of Egyptian fasting, like you are eating from the iftar, then till suhoor, you are all the day eating from like 5 meals per day, each meal small meal, and water between each meal you can drink up to 2 liters. Let me ask you about the difference between the sleeve and the bypass, because you said in your presentation that the sleeve will be a low risk and the one anastomosis gastric bypass will be moderate risk. Because in my experience, I think it's different, especially in some centers who do a tight sleeve. I don't do a tight sleeve for the last 6 or 7 years, so I don't have this problem. I usually have my patients can drink like 2 liters of fluids in the first month. But some centers still have the concept of tight sleeve, where the patient can't even tolerate 1 liter of fluids per day. And I think this kind of sleeve is more risky than the one anastomosis gastric bypass, when he can drink like 3 or 4 liters per day. So let me ask you, Dr. Salim, Dr. and Dr. Ala, about the one anastomosis.
Great question. Mine was purely anecdotal, but just because the data we had from the very limited data that published from Dr. Abdul Baqi and his group was all sleeve gastrectomy patients. In our study, me and Ala, the majority were sleeve gastrectomy patients. The ones published in 2015 and so forth, all of those, we have at least comfortable amount of data to say, well, sleep patients could fast very early, no issues. I think I will venture to say, again, this was just a roadmap. I'm not in no way saying that a one anastomosis gastric bypass should not fast earlier, but I felt like, at least from what we have and from the consensus that you guys have in the Delphi consensus, it seemed like a sleeve was, you know, it's more anecdotal. It's all, again, just based, and I think it's, again, the points I had were not necessarily meaning that if you have one, it's just kind of a collecting scoring. You guys could score everything. So if you have a one anastomosis gastric bypass, but the fasting period is less than 10 hours, well, I mean, So again, it's just anecdotal. There's no really experience. It's just that most of the data we had, at least in our study and Dr. Abdelbaqi's study and the others, was sleeves. And that's why I felt more comfortable maybe recommending it for the sleeve gastrectomy. But again, no really evidence. I agree with you. Sometimes bypass patients drink much more. I have the same experience in my patients than sleeve patients. They have less nausea and they drink more, even the roux wine. So you're absolutely right.
Yeah,
Let's
yeah,
move to,
yeah,
okay.
Dr. Professor Mohammed Abu Zaid, it's the same concept and the same results. If the patient pre-Ramadan, he's good and he's drinking well and his sleeve is not too tight and he can tolerate to drink water for more than 1.5 liters, so he will go very well in Ramadan. If these patients cannot drink well before Ramadan, he will not go well in Ramadan. So it's depending on the operative condition and the pre-Ramadan condition for those patients. And we can move this question to Muhammad Kirman Saravi and so his experience about difference between Ramadan fasting in sleeve gastrectomy or any other malabsorptive procedure.
Thank you. I agree with you. There is no high-grade evidence to support our recommendation, but it's just my opinion that it's better to delay fast 6 months after hypoabsorptive procedures that we reached in this point in our consensus. But after a sleeve gastrectomy, I think 3 months is better because the patients learn to chew more and tolerate the solid foods after 3 months. So I think I said that it's just my opinion. It's better to delay fasting 3 months to 6 months after a sleeve gastrectomy and 6 months to 12 months after gastric bypass, as reached in our consensus.
Can I mention one point that I didn't have time to go over in the presentation? I didn't want to overrun time. I think one other thing in the roadmap that I suggest is not to get focused on the temporary things. So I saw a lot of mention about micronutrients, about protein level and so forth. Remember, Ramadan is not a very long period of time. So if you have a patient who's compliant with vitamins for the entire year, and even if they're compliant, they will be compliant in Ramadan. If they're not compliant overall, they will not be compliant anyway. So I don't think if someone is low in vitamin D before Ramadan, we should make them fast. Or I don't think that month is going to make or break something. Even if they have perhaps consumed less protein, there's no evidence that that 1 month is going to cause these patients to have malnutrition and edema and all sort of things. So I think we as a group should be focused more on what practical and simple recommendation we should give Ramadan and not be too hung up on the little things, because we all have patients. Almost all of them are going to be iron deficient or vitamin D deficient. Then nobody's going to fast if we start digging into these things. And I think not to downplay it completely, but also remember that Ramadan is a short period of time, a month or so, and then there is enough time for patients to take their vitamins. So if they want to take them, they will take them in Ramadan. I don't know that necessarily Ramadan is going to make a big difference in those. I think we should focus more on the things are, when to fast and so forth. And I just wanted to highlight that.
Sure. I mean, I tell you, I agree with Salim, and I'm talking from an experience of taking care of patients who fasted regularly for 9 years while I was in Abu Dhabi. And 60% of what we did was Roux-en-Y gastric bypass. And we did not differentiate between sleeve and bypass. And we had a very liberal strategy to allow everybody to fast 2 weeks after surgery.
Wow.
And I tell you, we did not have issues with patients showing up with dehydration. We did not notice an increased incidence of complications during Ramadan. And I tell you, until I came back to the US in 2018, we did not change that practice. And I have not heard that there are things different. So I usually don't tell patients 6 months. I tell them within 2 weeks, if you're able to get up before suhoor, if you're able to drink without having dumping symptoms and you don't feel dehydrated, you should give it a try.
Completely true, Dr. Abdulrahman. That's also what I do with my patients. And I have to add to Dr. Salim that usually when the patient says that he can't eat enough proteins during the fasting time, we add isolated protein 1 scoop per day. It helps a lot with the patients, especially in malabsorptive procedures, if they can't have the good amount of proteins per day. There is also according to the dietitian in our center, because most of the patient, usually they are very keen to fast and to follow up with the dietitian during the Ramadan era or timing more than during the year. With pregnancy, with fasting, patients tend more to follow the instructions of the dietitians more than the rest of the year.
Can I ask both of you, Abdurrahman and Salim, because you are an expertise in SADIS, and I have a little experience in SADIS. I'm still in my early career for this procedure. So with this type of procedure, or ileal surgery, or distal small bowel surgery, so what's your special recommendation for those patients? Because me, I do a SADIS with a 52 French bougie. I see that Professor Abdurrahman, I think he did it in a 40 French bougie or 42 French bougie. So my patient is drinking very well and he can eat a good amount of protein. But regarding the Ramadan and fasting, do you have any special recommendation for those patients regarding protein intake and vitamins? And does we need to increase the dose of vitamins for those patients? Thank you.
So for me, I'll have to take that back. I am not an expert in SADI. In SADI, we don't actually, was recently, recommended in the, approved by the SMBS or recognized by the SMBS. Insurances mostly don't cover it. So I don't have a very big number of SADI patients that I can give recommendation. And I also don't have fasting patients. So it's hard for me to give the recommendation, but I will say, I don't deviate in the bougie size. I use the same bougie size we use, which is 40, because it's a lighted bougie, but I go very wide. So I don't use the bougie necessarily to guide my sleeve, because we have the endolumic, which is a lighted bougie that we see, and I don't have a bigger size of that. So I use the 40, but I go very, very wide. Our dietitians tend to be a little more aggressive with protein recommendations. We use DS specific vitamins, not the regular Roux-en-Y and sleep vitamins, because in the US we have DS vitamins. But it's a discussion for a different talk. But I seem to be on the other end when it comes to protein. I am not a big fan of protein all the time, because patients end up choosing very poor quality protein, eating a lot of fatty food, end up with a lot of diarrhea and so forth. So I'm not a very big aggressive, but I'll say, yeah, in our practice, we do obviously recommend a higher protein intake for the SADI. But again, I'm not an expert in that field by any means. I probably have done way less than what you've done.
I agree with Salim. I have a pretty good experience in Saudi and DS, but none of my patients, since I've been back in the US, have been fasting. And when I was in Abu Dhabi, these were procedures we would avoid in our patients. I mean, at that time, there was no Saudi until 2018. And DS was a procedure we were trying to avoid in our patients when I was in Abu Dhabi, because of concerns of nutritional deficiencies. And typically, like Salim said, we let them take vitamins that have high A, D, E, and K, like fat soluble vitamins. So I mean, I would tend to treat them similar to gastric bypass if I was you. I mean, and then see how they do. I don't suspect it will be much different. I think a liberal strategy is reasonable. I think what's important is the one thing we've noticed, I remember in Abu Dhabi, was kidney stones. During Ramadan, many people come up with kidney stones, especially patients who had bariatric surgery. And we used to see kidney stones more in bypass than sleeve patients. And ASMBS has a position statement that shows that. I would suspect in patients with SADI and DS, they would have more likelihood to have kidney stones. So that would be the concern in terms of hydration. But other than that, I don't see another issue. So if someone has, chronic renal insufficiency, I would be careful so they don't have worsening kidney functions.
I want to add one more thing on that, because I skipped through that slide earlier, is basically we will consider some of those patients to be stone formers. This is what the urological, people call the urology people call it. It's a stone formers. And that is not a matter of month. And those people should be encouraged always to drink more, generally speaking, because we will venture to say the stone is not going to just form in Ramadan. It just spikes in Ramadan, but the stones are there from before. The formation of stones happen throughout the entire year. And the American Urology Association recommends that stone formers drink enough liquid to generate 2.5 liters of urine a day. It's not about how much they drink, it's about how much urine they make every day. That makes so the stone formers probably need to drink much more liquid period throughout the year and not just Ramadan. That's an important thing. But yeah, perhaps in Ramadan even more vigilant about that. One thing we do different with the SADI patients is we do test labs more often. So usually we do annual lab visits for the Rowan-Y and the sleeve, for the DS and SADI in our center, because it's a new experience. We're doing it every 6 months. And we're finding it really hard to keep up with vitamin deficiencies because patients don't take vitamins. I think so. We chase them down. We do them every 6 months to ensure that's working.
Okay, we have like still 5 minutes, 4 minutes actually, till the end of the of this very, very fruitful webinar. So if anybody have any more comments or any more guidelines, recommendations, please add it.
Yeah, just a question to all of the panelists here regarding a patient with post-Rowan-Y gastric bypass and he has a marginal ulcer and he take his treatment. Do you allow him to fast or no?
I'll say no. Treat ulcer first. That's in my opinion. Treat the ulcer first, make sure it's healed, and then do a lot fast. That's kind of playing with fire, in my opinion. We know the patient has a marginal ulcer. If it's a known marginal ulcer.
If it's healed but still early, you will allow him to fast?
If it's completely healed and improved by endoscopy, yes. Put them on PPI and allow them fast. At least, again, this is anecdotal. Yeah. Understand that I don't have patients that fast, but I'm just thinking that's what I will do.
Yeah, same here. I mean, I tell you, when I was in Abu Dhabi, in non-bariatric patients, we would see a lot of patients with perforated duodenal ulcers. They were mostly workers who work and individuals who haven't had bariatric surgery, but we used to see a larger number of perforated duodenal ulcers. So if someone has an ulcer, I would tend to wait until it's healed.
Yeah, also patients with hypoabsorptive or malabsorptive procedures and having attack of diarrhea during the fasting, I will ask them to stop fasting till the diarrhea is over, because diarrhea is an alarming sign during fasting that you have to stop and have some probiotics and healthy food, because hypokalemia and losing lots of fluid in the diarrhea is pretty critical for the patient.
Muhammad.
I think the most important point to allow the patients to fast is re-education of the patients before fasting. And we should decide person to person, according to their education, to their comorbidities and the time of their surgery. So an MDT evaluation before fasting is essential, and I think is the most important point that should be noted before fasting.
Thank you. Do you have any question? Muhammad Abu Zaid, Salim, Abdul Rahman.
Thank you very much. Appreciate the opportunity. That was a great discussion, and looking forward to seeing you all in IFSO, and maybe you can come up with something together.
Likewise, I want to thank Muhammad Abu Zaid and Ala for the kind invitation from the Communication Committee of the IFSO MENA chapter, and Salim for an excellent presentation, and my co-panelist Muhammad Kerman Saravi. This was really fantastic.
Thank you. Thank you all for these nice presentations and nice webinar. Bye-bye.
Thank you. Take care.
Thank you.